Yeah. First of all, thank you for the invitation to be here and for Myeloma Canada to be organizing this event, and you guys for your presence here. So I'm going to try to give a little bit of understanding of all the different diseases that have to do with something that we call monoclonal gammopathies, which is people with myeloma and amyloid, which is something that I also treat in the clinic. Everyone is pretty much preceded by this condition called monoclonal gammopathy of undetermined significance. And that means that they have something that at some point become defective, and there is a trigger that just makes this turn into myeloma or amyloidosis and sometimes lymphoma. So I'm going to give you a little bit of understanding. I know if Nisar is talking a little bit more about treatment, but I'm happy to pause and answer any questions that you guys have within the meeting. Just let us know so we can give you the mic. And if there is any questions about generalities on treatment, we can go through those at the end of the day. So this presentation is aimed to be around 40 minutes, so you guys have 10 to 20 minutes to ask me any questions. But we're going to talk about those monoclonal gammopathies and how myeloma is defined, and how there are other entities that are not necessarily related to myeloma, but that can be actually mimicking monoclonal gammopathy, and sometimes there are clinical significance to those diseases, and we can treat it with the new drugs that we have available for myeloma. So these are my disclosures. So when we talk about monoclonal gammopathies, that means that there is something in the bone marrow that is changing, and it's making a group of cells that we call plasma cells become cells either defective or cancerous in the forms of myeloma. Amyloidosis is an entity with these proteins that are made by the plasma cells don't actually require necessarily a lot of plasma cells to make them. The median number of these cells is actually less than 10% for the most part, so a lot of patients are actually sometimes confused with diseases that are not really causing any trouble. That's just because if they do a bone marrow, they might not see 10% or more, which is the arbitrary number that we use to define myeloma. We're going to talk about it. But if you look at this germinal center on the B cells and the plasma cells, which is the plasma cell is a more mature form of these B cells, those are the responsible for making antibody. That's what they do. The whole function of these cells is making antibodies that help us fight infections or inflammation. But there are many circumstances under which these cells can be stressed. And that can be chronic infections, chronic inflammation, and at some point the cells get so overwhelmed that they start becoming defective. And then another thing that can actually trigger this process is just aging. As we get older, everything in our system gets older, and people can start making proteins that don't make sense just because the cells become defective. Not necessarily cancerous, but they can be just defective, and we think that that's the nature that you go from a defective cells and then something makes you develop myeloma. So we talk about genetics, and you can see at the bottom that there are some genetic changes that perhaps are the responsible for making these cells to become defective. And then at some point, there are other genetic changes on the cells that actually make them turn into myeloma. And then we have two groups of myeloma. The one that does have symptoms and we have to treat right away, and the one that doesn't have symptoms and can be stable for a few years before actually people need treatment. And there are some people that actually don't need treatment down the road. So that's what we call a smoldering myeloma or asymptomatic myeloma. Myeloma that is there, it fulfills this 10% criteria that we arbitrarily define, because most of people with myeloma do have more than 10%, and that includes around 99% of patients by cutting up the number to that level. But in reality, a small proportion of people can have myeloma with less than 10%, but that's a very minority. That's why we use that cutoff point. So a lot of people ask whether myeloma is an inherited condition because a lot of genetic changes occur in the plasma cells, and the answer is, for the most part, it's not a genetic disease. It's not an inherited genetic disease. It's something that happens very likely in some people that are more susceptible than others. Why this happens in some people, you always can look at some chemicals, and some people might be exposed to chemicals in the past. Some people might never been exposed to the same chemicals and still they develop myeloma. So in terms of what is the cause of the disease, it's really hard to pinpoint one single event that perhaps might be related to that, but we know that there might be perhaps a combination between something in the environment and people that are susceptible to develop cancer, not necessarily just myeloma. Cancer and some genes are particularly seen in different cancers, including myeloma. And we're going to talk about some genetic markers. But these cells actually turn from this phase of just being defective into myeloma cells, but it doesn't occur in everyone. So people might think, is there a way for us to predict who is going to develop myeloma? And the answer is because this monoclonal gammopathy of undetermined significance, which is a term that we use for people that do have these affected cells making proteins that don't make sense, but they don't cause any trouble. That's a benign form of kind of the benign form of myeloma or amyloid. So the problem is that it's so prevalent as we get older that you can see around 3 to 4% of people at the age of 50 that might be harvesting these proteins, around 4 to 5% of people at the age of 60, 5 to 6% of people at the age of 70, and especially on male, 8 to 10% of people at the age of 80 might be harvesting these proteins, and most of them will die of something that is completely unrelated. There is just a small proportion of people that actually will transform into myeloma. The problem is that screening all people at that age might not be actually cost effective because most of people will not transform into myeloma, and secondly, it adds more the psychosocial issues of having something that you don't understand. Is there any way for me to predict that I'm going to evolve into this cancer? So it also adds some stress on people thinking about what if this really changes into something. And we didn't know the frequency of those problems, but in the Iceland, in an Icelandic project, they actually screened more than 40,000 people that were volunteers, and they did just tests. They didn't have any symptoms. They said, you want to participate in this study. We want to see how many people might be harvesting these proteins, and then discover that there is around 3 to 4% of the whole population over 40 years old that actually do have this monoclonal gammopathy, this MGUS. So just to tell that is something that is quite prevalent, and obviously screening everyone is not necessarily the way, but that study will help us understand perhaps what is the people that might be more predisposed to develop myeloma, and perhaps give us a little bit something better to tackle on, which is prevent the disease from occurring, but understanding better what is the mechanism by which this happens, why people develop myeloma, and perhaps do some form of interception, so doing something before actually the cells trigger into myeloma. So that's the hope for the future, that we can actually make that. And the other thing is that if we discover or we understand better why the cells turn into myeloma cells, we can actually try to use those knowledges to actually better identify new treatments that we can actually use to revert the cells from being cancer cells into cells that are just chronic cells that are defective, that they don't grow much, that they don't cause any trouble. So that's also the future, that by investigating these cells, we can actually learn more, get more knowledge on these cells, and potentially come up with better ways to tackle down and improve the treatments that we have. Nizar Baylis is going to talk to you about all the research things that we're doing, the bispecific, the CAR-Ts, all the new treatments that we have available, and those have significantly improved the outcomes in patients with myeloma, and we hope that whatever we have today will be better in 5 to 10 years, and that's the goal. But you can actually get an idea that by investigating what myeloma occurs, we will actually get more knowledge that can help us understand better why this happens, and perhaps use that knowledge to better treat people with myeloma even when that occurs, and possibly to treat people earlier, preventing the damages that can occur when people develop myeloma. So preventing fractures, preventing kidney problems or tumors that are growing. So that is where the future is actually moving, is trying to intercept the disease before it causes a lot of trouble. So the hope is that even if we don't cure everyone, the hope is that we can cure people just by making them live long enough that they die of something else. And that's what happens with diabetes, hypertension. So we want people to live long enough that they die of something else. Unfortunately, we don't cure aging. So what we want to do is to try to get people to live as long as possible with the best quality of life. And if they die of something else that is part of aging, that is what we call functional cure, meaning that we get them to live, we get you guys to live long enough that you enjoy your quality of life, but also you die of something that is not necessarily related to that. So that's the hope for the future, and that's why we're doing a lot of investigations, and some of the treatments have actually revolutionized the outcomes these days with responses that we didn't see 10, 15 years ago. So there is hope that we can actually use the knowledge to improve the treatment outcomes. But that's kind of the phase that we're going to talk about. When myeloma occurs, that means that these cells now turn into cancerous cells. And the myeloma is not only one myeloma cells. They look the same when you look at the bone marrow, which is where the cells come from. That's why we do the bone marrow biopsies. Unfortunately, there is no test that we can use to replace that these days. And I know you guys might be familiar with the bone marrow biopsies, and nobody might necessarily like them. The problem is that that's the only test that we have available to look at the cells, to do the genetic tests that we have to do, and to better understand how the other benign group of cells are actually behaving in the bone marrow. So this is a slide when you can see myeloma is termed myeloma, that the myeloma part is tumor from the bone marrow. That's what myeloma means. And multiple is because in the bodies of people suffering from myeloma back in the 1500s, 1400s, they discovered multiple holes in the bones, which is kind of the presentation of most of people with myeloma, having 80% of people presented with a lot of lytic lesions. That's kind of the holes that we see in the bone marrow, because the cancer cells grow and start chewing the calcium from the bones. So that calcium is thrown from the bones themselves into the blood, so people can have the calcium really high in the blood. And people might say, why my calcium is so high if you're saying that my bones are really frail and they don't have a good density? That's because the calcium is taken from the bones, thrown into the blood. So in the blood it's high, whereas in the bones it's actually less. So that's why we do these treatments that are not aimed to kill the myeloma cells, but that are aimed to replace that calcium and fix the calcium with the vitamin D. And that's the bisphosphonates like the Zepeda, the zoledronic acid, or the palmitonate, which are the bisphosphonates that help us with osteoporosis like of conditions. But that's the reason why this is called myeloma, because they identify these multiple holes. But nowadays we know that even when the cells, if you look at the cells right here, they look alike. But there are at least 4 to 6 different groups of cells that are genetically different. That's what we call multiple myeloma as well. Because the myeloma cells, even when they look the same, we call it morphologically, meaning that the picture looks the same. Patients actually do have cells that are genetically different. I'm going to show you a slide on that. That means that the cells genetically differ between themselves. And that's what actually is challenging for the treatment of myeloma, because there are a group of cells that might be the ones that give you the disease at first. You treat them, they get better, and then the other cells can actually become resistant just because they genetically change themselves. So when people treat myeloma, you have to think that every time that we treat a myeloma patient, we're treating a different myeloma. Even within the patients with myeloma, within yourselves, you guys have a myeloma that a diagnosis might be different than on the first relapse or the second relapse or the third relapse, because every time that the myeloma relapses means that it's understanding how to survive, understanding how to evade the treatment response, and that's essentially why we had to switch the treatment, is because the cells are becoming smarter. So that's why identifying the disease before it happens makes a lot of sense, because we can actually target the root, not only just go and kill the cells, because that comes with side effects, but identifying perhaps why the cells are turning into myeloma, so we can hopefully reverse to that. But there are 4 to 5 different population of cells that they look the same but are genetically different. And that's what makes myeloma different, is that every single patient, we might have to individualize the treatment, because you can think that the cells that you have from the myeloma are different at the time of diagnosis, and then they change over time. So that happens within yourself. Imagine comparing with other patients. That's why every single patient with myeloma is unique. And the treatments that we use, we try to use the ones that are more potent for everyone, but in individual basis, it might be a little bit tweaking on the treatment depending on how they respond. And there are a few things that we take into account with that, but most of the cells are unique in terms of making a monoclonal protein, and that's the myeloma market. We call it myeloma protein or myeloma spike or M spike, and that can be seen sometimes in the blood, sometimes in the urine. There are 2 different types of antibodies or forms of measuring the antibodies. When the myeloma occurs, the cells that normally used to be antibodies are made of kappa and lambda, and you have immunoglobulins that are IgG, IgA, IgM, IgD, and IgE. When myeloma occurs, the cells make a unique type of monoclonal protein. And that can be sometimes IgG kappa, which is the most common. But that is around 60% of people with myeloma, and there is around 10 to 20% that actually can make the IgG kappa, but also make just the kappa portion without the IgG. So the reason why we do those tests is because once we diagnose someone with myeloma, we want to have the picture with all the colors on how you guys have your myeloma, so we can actually compare the different variations on those colors over time once we do the treatment to see what the benefit of the treatment is. So the reason we measure the markers and we say the protein needs to go down is because the cells grow, and as they grow, they make a lot of these proteins. When the cells are killed, the cells are depleted in number, and these proteins are made in less frequency. So the reflection of this protein is having less of the myeloma cells growing, That's why we measure the protein. It's not that we want the number just to be down. It's because the number reflects that you have less cells making those proteins, and the lower that you get will signify the lowest amount of cells growing into the bone marrow. And that monoclonal protein or that free light chain is unique for each patient. Even when we say it is an IgG kappa, some people might have IgG kappa with a lot of kappa. Some people might have IgG kappa with something else on top of that, an IgG lambda. So it doesn't make any difference in terms of what type of myeloma you have. It makes a difference just in terms of the way we follow those tests. And we're trying to replace the urine from being collected, and for the most part, we recommend to do it at least every few months. But with the free light chains that we have available, that can be actually a good correlate to try to avoid the urine tests that often. And with the pandemic, we started doing actually less urine tests. I don't know, it might be your experience. In my case, I do more because I also see amyloid, which is a little bit different, affects the kidneys, and we have to measure a different protein that if I do only the free light chains, I will be missed. But in the case of myeloma, we have to do tests in the blood, we have to do tests in the urine, perhaps the urine a little bit less often. And the X-rays help us understand what the disease is up front. We don't do PET CTs for everyone, but we do sometimes MRIs. We do PET CT for some people that we might think there is a potential tumor that we can see. And those are the tests that we normally do at the time of diagnosis. Once we know, there are some special tests that might come for patients depending on the individual basis, what kind of symptoms you have, whether there is a pain in the area of the liver or the spleen that we have to look at. There are some people that can have both, the myeloma and the amyloidosis, so we have to look at organs. And we're going to talk about the amyloid part because we're going to get you a little bit of overview of other diseases that can be related to these proteins, and sometimes it's not easy just to see these proteins and say, oh, this is not myeloma, it's done. Sometimes there are other diseases that need to be treated because they give symptoms that we have to investigate further. Okay, so when we talk about this group of cells, I mentioned to you that there might be between 4 to 6 different clones, and we call it clones. It's just to show that they have genetically different variables. And this is a patient that actually donated the bone marrow throughout the whole journey of her myeloma. It's a patient from Arizona that was actually treated with different medications, whether were standard of care or clinical trials. And the patient actually donated the bone marrow. Every single time that the treatment was not working, the patient had a bone marrow, and the bone marrow was actually looked at from the genetic component. So if you look at the cells, this is what we call at the top cytogenetics, and we look at translocations that have to do with a chromosome, the chromosome 14, where the IgH, which is kind of the immunoglobulin heavy chain gene, is located. And there are some translocations that actually can't tell us whether the myeloma can be predicted to be more aggressive. So in this patient, there was a presence of a translocation 414 and 17p, but as you can see based on the colors, that's different clones. So meaning that there were 4 to 5 different cells that were different genetically. They look the same in terms of the picture of the cells, but they have these genetically diverse changes on themselves. So as you can see in the first one, there might be around 3/4 cells. Then patient got treated. Then the treatment made one clone to be a little bit less, and then that clone disappeared with the next treatment. And then other clone, the one that was only 10% at the time of diagnosis, started expanding. Then the treatment was switched, and then there was the other clone that was more present in the remission process that actually emerged. Then the patient needs another treatment, and then the clones start to expand and relapse until it becomes green. And if you look at the first one, the tiny part on the pie, the tiny one is less than 1% of the cells were actually the clone that emerged at the end of the journey of this patient. And that's because the cells become resistant by changing from within, but making themselves more genetically diverse and changing by becoming more resistant. And when that happens, then that group of cells that was really tiny at the beginning is actually the group of cells that is driving the most aggressive form of the disease at the end of the course of this journey of myeloma. So that is just to tell you how complex these cells can be and how the treatment sometimes can be diverse even for people that you might think, oh, my first relapse is treated with this, but this other patient is treated with a different treatment. And that's because One patient might be actually not responding that much to bortezomib, and then we have to add something or tweak a little bit the treatment to make it work. That's for this particular reason, because you have certain cells that might be more sensitive than others to certain treatment, and there might be others that might be more resistant, so we have sometimes to make the adjustments on the treatment. So the reason why we combine the drugs is because some of these cells might be sensitive to one medication and some others might be sensitive to another. So by combining them, you try to tackle down most of the cells that you're seeing here. But that makes it more complex, because that means that the cells can actually learn over time, because they're genetically different. They can become resistant just by learning how to survive in the setting of those new treatments. And that's the reason why when the treatment doesn't longer work, we have to find something new and change it. Any questions to that part? Okay, so we always talk about individualizing the treatment in people with myeloma, and to be quite honest, we have done that for many, many years. Individualizing doesn't mean that we have to know what are the genetic abnormalities that we saw before to treat patients. It's meaning to know how patients actually look like, how fit they are, what are the particular needs. And needs can be whether they get access to cancer centers in an easy way, whether patients might not be able to go to the cancer center and will prefer a treatment that is all oral. With the pandemic, we try to make people safe and avoid coming to the hospital that often by switching sometimes treatments to something that can be just given orally at home rather than coming to the cancer center quite often. There is some people that don't have a lot of veins and say, coming to the cancer center to get something injected is not a good idea for me. Some people might say, I don't have anyone that can actually bring me into the hospital, so that's very challenging. Some people might not be that fit to tolerate the doses that we normally do with every single regimen, so we have to make some adjustments, and those might have to do with the age, but also can be related to other factors, how active they are, whether they have other medical problems, because there are some medications that can affect the heart, some medications that can affect the kidneys or the livers. So people, as we get older, we can collect sometimes diseases. We can have problems on the heart, problems on the kidney and the liver. So when we talk about the medications that we have, we always talk about the side effects, the possible changes on these organs. And then we always talk about the different options, and we help you guys decide what might be the treatment that can be more beneficial but also less toxic. So the main thing is whatever treatment that we can do, we want to use it for longer. So we want to make sure that we choose a treatment that is the most effective, but also that gives you the best quality of life, because that's what we always want to do. So even without fancy genetic testing or fancy studies on the bone marrow to understand what kind of myeloma cells we're facing, just by looking at you, just by knowing the diseases that you have, we can actually try to individualize your treatment to give you the proper medications and the proper dosages that we think can control your myeloma, but also give you the best quality of life. And sometimes we might be wrong. Sometimes we think that this is what you might be able to tolerate and can help you to control the myeloma. But the only way for us to know is by trying and seeing how you react to that. And sometimes people might be more sensitive to some side effects. Some people might not be that sensitive. And sometimes we have to make some trades. And we know this is the side effects that you're going to have. We can give you something for the symptoms or the side effects that you're going to experience because the treatment is working. But obviously, the quality of life is affected really badly. Sometimes we have just to switch to something else. Even if the myeloma is well controlled, we're not going to make you feel miserable just by trying to give you something that we think that might be the best. So we have to always work out with you guys and see from the options that we have what might be the best option for you. And what is the best option for you might be different from other patients in kind of the same scenario. Like you see, oh, this is my second treatment. Why am I getting this? And this other patient is getting that, because you guys are different. Even from yourself, the way you are at the time of diagnosis might be different from 5 to 10 years before, because you will go through different chemos, different side effects. Your bone marrow is going to be different as well. So there are many things that we use or we consider when we're actually treating you guys. And those are the things that we want to do. We want to give you the best treatment for the longest, but also to preserve the quality of life. And why we always want to do the best treatment up front. We know that people with myeloma present with the disease at the age of 67 to 70, depending on where you are. Our kind of average age of diagnosis is around 67 here in Calgary. So that means that around 30% of people might be eligible for what we call a stem cell transplant, which is getting you some chemo for a few months, and then after the chemo is given, to collect your own cells from your bone marrow by stimulating the cells from the bone marrow to grow and take only the good cells, and then use a high-dose chemo and get the cells back so we can actually kill the bad cells and get these new flowers or new stem cells that will repopulate the bone marrow with healthy cells and hopefully will stay there for longer. That is something that we only offer for around 30%. We know that with the transplant, sometimes we hit you really hard for a short period of time, hoping that I will keep the disease control for longer. So it's kind of a trade between a hard few months with good few years, hopefully, of response and quality of life. Now we have new treatments that we're trying to prove to replace transplant, and those are being investigated in many people, and we're closer and closer to use new treatments that could potentially give us the same or even better than transplant. But as it is right now, transplant continues to be important in people with myeloma. But only 30% of patients with myeloma might be eligible for that, and that has to do with age. Sometimes people are younger than the age that we set up for the transplant, but they have a lot of medical problems that can increase the chances of complications, and we say this might not be for you. And the people that are not eligible for transplant are people that are older, that might have other medical problems. So we want to give the best treatment because a lot of people at this age, they can have other medical problems and they can die of something that has not necessarily anything to do with myeloma. You can have a heart attack, and the myeloma was just part of the treatment, and some of the treatments that we do might give you some side effects, but that might not be the cause you're dying. So we have to do the treatment that is the best at controlling the disease, but that can actually give you the longest duration of that treatment to keep the disease well controlled with a good quality of life. And we have something that we call attrition rate, which is the possibility that someone that is diagnosed with myeloma goes from the first line of treatment to the next one and then into the next one. And the people that actually qualify for transplant are people that are younger, and normally we can actually proceed from one line to another and another. But the ones that are older, only 50% of people might actually go from the first treatment into the second one, and then from the second one into the third one. There might be another 50% of people that might not be able to progress into the next treatment because they can actually have other problems that can actually limit the ability of getting the treatment. So that's why in myeloma, we never reserve the best treatment for later, because there is no guarantee that there's going to be later. And I don't want to sound fatalist, but that means that if we want to get you the best outcome, we have to give you the best treatment. And as I said, the best treatment is different from one patient to another, but when we talk about the options, we always try to get you the best alternative at that time, because there is no reserving the better for later. The myeloma cells change, and there is no guarantee that the myeloma that we're facing that perhaps might be less aggressive at that time, there is no guarantee that it will remain the same in the next line of treatment. So reserving the best treatment for later is not what we do in myeloma. There is a lot of things that have to do with access. We have to show that the treatment works and it has to be approved and those other things. But when we talk about all the options that we have at a given time, we like to give you the best option in terms of keeping the disease well controlled. And then within the options, we'll decide what you guys might prefer and what you may think is best for you. So that is one of the reasons. We never reserve the best for later, because we never guarantee that it's going to be later. Sometimes in people that are really relapsing and we know that the myeloma is more aggressive, what we try to do is to provide new drugs and new treatments that could potentially be better. And those sometimes come from clinical trials, and you guys might be familiar with clinical trials. I don't know how many people have been in any clinical trial drug here for myeloma. You want to raise your hands? So not many, but the clinical trials are options when we know sometimes that the drugs work, but there are different phases. The phase one is when we want to know what is the right dose and we want to make sure that the treatment works. Then we move into the phase one when the clinical trials are done in people with drugs that we know work. We know what the dose is, but we have to prove that it still works in combination with something else. And then the phase three comes, and the phase three is when we know what the dose is, what it is the effectiveness, but we need to compare with the standard of care, the treatment that is already available, to make sure that it's the same or better than that treatment. And that's the way these clinical trials are. So we have a good group here in Calgary in terms of the research portion for myeloma. where we normally offer patients not only the standard treatments that we have available, but also sometimes clinical trials where we can get access to new treatments that we normally select for what we call unmet needs. So for people that we know might need a treatment that perhaps doing what we have available might not be the best, so trying to get access to new drugs or new forms of treatment in myeloma earlier can actually come from getting people involved in clinical trials where you don't have to pay anything. Sometimes you get actually a little bit extra care because there are extra tests that we have to do as part of the trial to make you safe. So the clinical trials help us understand what the treatments work and sometimes getting access to people earlier to these treatments. And that's something that we have done, for instance, with the CAR Ts or the bispecifics, which across Canada, we have access to those drugs through the clinical trials even before than other centers where they have no clinical trial groups and they have to wait until those drugs are approved. So those are the treatments that we normally consider, and the reason for the treatments to be given as soon as we know they're present is to do that. We said that this MGUS disease or benign form of monoclonal gammopathy is what precedes myeloma. So what can we do to define if a patient might be at risk of progressing into myeloma? So we have in Calgary a clinic where we see these patients that might have these monoclonal proteins that are not related to myeloma, but that could potentially evolve into myeloma. So the investigation of those cells and those population will help us understand why myeloma occurs and perhaps to detect myeloma earlier. These are three conditions that are not cancer. The first one, we call it clonal hematopoiesis, which means you have defective cells, the cells that help us fight infections, fight inflammation. That is the premalignant form of leukemia. The second one is called monoclonal B-cell lymphocytosis, which is in red. That is the premalignant form of lymphoma, which is a cancer of the lymph nodes. And the third one is this MGUS. If you look at the three premalignant conditions from these different hematological cancers, leukemia, lymphoma, and myeloma, you can see that as we get older, these benign conditions actually get more often seen in people. And that's essentially what happens is we get older and all the cells in our systems start to get older and they start getting these changes on the genes. These are three different types of genetic abnormalities that we can see in people with this MGUS. They're similar to what we see in myeloma with some variations. So by looking at those people, we can try to identify from those patients that don't have myeloma or have myeloma without symptoms, whether these genetic abnormalities can be seen in people that might actually be led to progress in a more frequently fashion. And you can see they did the genetic assessment on the cells on people with myeloma or myeloma without symptoms or this monoclonal gammopathy, this premalignant form. And they discovered that the people that do have a more progressive form of disease, meaning that they activate into myeloma sooner, they have actually more cells in the bone marrow that are looking abnormal. And they do have also some markers on these genes that are actually more common than people that don't progress into these diseases. And when you look at the separation of this, the ones that are really stable on the left at the bottom are patients that they don't progress into myeloma, but the ones that do have these changes on this set of enzymes or genes that has to do with what we call APOVEC, they start to get higher levels of expression as they progress or they become active myeloma. So this is just to show that we can actually look at those cells and perhaps predict what are the patients that might evolve into myeloma and look at them in a closer way and perhaps start using some medications that might not be that toxic in that population. So we can actually prevent them from turning into myeloma. We're not to the point of getting to that, but as you can see, these are just genetic changes. The genetic changes means either gains of some parts of the chromosomes on the genes, or some losses or some parts of those chromosomes on some of the genes that we have. So the more red or the more blue signifies more gains or more losses. So you can see the myeloma in the bottom, there is a lot of reds and blues. But in people that are really stable, you can see the same. So even in early phases, you can see the genetic changes, but they are not as pronounced as they are when people develop myeloma. So what is the hope? That we can actually intercept the disease perhaps in the middle, and only the people that might behave more like myeloma either treated like myeloma sooner before they develop symptoms, so prevent people from getting fractures or kidney problems or tumors growing, or at least get a more close-up on those patients and intervene before they have a lot of damage on these organs or they have a lot of symptoms. So that's why getting these diseases investigated or having assessed in a proper clinic help us. And this is, if you look at the bar at the end when it says the total, we normally receive between 300 to 400 referrals to our group every year with people that might have these monoclonal proteins. And they have to be investigated to first rule out and make sure that they don't have myeloma, lymphoma, or amyloidosis, but that could potentially can use for learning and for research to better identify the people that might be actually having any issues. And what are the reasons these patients are referred to us? Some because they have kidney problems, some they have already nerve damage, this numbness tingling that sometimes people do have with the chemo. Some people investigated with osteoporosis, or they have this chronic inflammation of anemia that they don't identify a cause, and they do this test and they find this. So by doing all these tests, and this is kind of a group we looked at, 565 patients, and you can see that people do have a lot of medical problems. They have blood pressure problems, cholesterol problems, diabetes, and other medical problems that actually can affect their quality of life. But if we can identify those people before they progress into myeloma, that will help us actually to give the best treatment earlier and perhaps reverse the changes that we see. And there are different diseases that actually are related to these proteins that are not defective, but these are proteins that people can actually have manifested because the cells are defective, or people that truly have these proteins because there is some changes in the kidneys or some changes somewhere somehow that we need to treat. And that's what we call monoclonal gammopathies of clinical significance. They are not related to myeloma, they are not related to lymphoma, but they do have medical problems that we can actually treat. And there are some people, this is just to show that most of patients with myeloma are actually preceded by this monoclonal gammopathy of undetermined significance, meaning that they have a monoclonal protein that is produced by defective cells and they turn into cancer cells. And there are some that make light chains only. They have the same risk to progress into myeloma that the ones that make this IgG kappa or IgG lambda. And there are some that actually progress more into lymphoma that are based on the IgMs. Now we have different tests that we can actually use to identify these proteins in a very sensitive way. And the hope is that we can use those to actually define the population that might have these monoclonal proteins even really, really early and follow them out more closely. And you can see that patients that do have myeloma, these tests also help us to better monitor how they respond to the treatment, even very sensitive tests that can help us understand whether the myeloma cells are killed completely and they don't make any proteins. And sometimes they can help us to identify other conditions where they don't have myeloma, but they have proteins that actually make some symptoms. This is, for instance, the amount of sugar that they have, and the people that do have a lot of sugar on these monoclonal proteins that are actually linked to something that we call amyloidosis. So there is a potential that we can do in these people with MGAS. We can do this test perhaps to define, oh, this patient might be progressing more into amyloid. Why don't we do other tests to make sure that they don't have amyloid? And we know that a lot of people, before they get into these defective cells, they make what we call polyclonal cells, where the cells that make antibodies are overstimulated, and those are the proteins that actually start making proteins that don't make sense. And this is what we call polyclonal plasma cells. So these cells that make antibodies, they're not defective yet, but they're overwhelming. They're overwhelmed and start making proteins that don't make sense until they just get not only overworked, they get defective. And that's moving from the polyclonal phase to the monoclonal phase. So there is a potential that we can even go back to the first step when these cells are not yet effective and try to reverse that by doing some treatments that potentially can affect the inflammation or can actually make those cells reverse. So we're not to the point that we have that strategy in place, but by having a clinic that look into this, we could potentially identify patients that do have symptoms that could potentially be treated that are not only myeloma, lymphoma, amyloidosis, and this is just a list from those 565 patients. This is almost 40 people where they have problems in the kidneys, problems on the nerves, and problems in other places without having myeloma. So by looking at them, we could potentially identify the the right diagnosis and start working on them. And these are the symptoms. So you look at the cells looked around the same. This in the middle on B is actually what we call sclerotic lesions in a patient that doesn't have myeloma, but has something that is quite rare called POMS. POMS syndrome is something that is associated to neuropathy, skin changes. It has a lot of problems in different organs, but they have some cells that look like myeloma in the bone marrow, but it's not myeloma. So by looking at these clinics, getting these people, we could potentially identify also other medical problems that we can treat to the point that actually they can get good symptoms. There are some people that do have skin changes. Sometimes they get deposits of cholesterol plaques on the eyes, and they have also monoclonal proteins. They don't have myeloma, but they have something that we could treat with the medications that we normally use for myeloma. This is a bunch of different diseases where the kidneys or your body make a lot of proteins that go into the kidneys and get deposited, and we could potentially reverse this by using a medication called bortezomib that can actually prevent these proteins from being formed. Patients don't have myeloma, but they have kidney problems that are not myeloma related that we can actually treat with drugs that we use in myeloma. So getting these clinics where we see these patients can help us to understand what are the people that might evolve into myeloma, the people that might have other problems like amyloidosis or other diseases in an early fashion. And we do have in Calgary a clinic that actually help us with this. One of the examples is amyloidosis. It's a disease that normally is diagnosed when it's too late, when people do have a lot of damage on the heart, on the kidneys. So by looking into these patients, you can see that most of these people have to see more than 4 different doctors before they're actually diagnosed with these diseases. Most of those actually have an increase of these free light chains even 4 years before they are diagnosed with amyloid, and they can actually affect the heart or kidneys. So we have markers from the heart that we can actually look at. We have markers from the kidneys that we can look at, and potentially from those MGUS patients identify the group of people that be more at risk of developing amyloid and treat these people with amyloid better. If you have an MGUS clinic, for every 7 patients that evolve into myeloma, the risk for someone with these defective cells called MGUS to evolve into myeloma is around 1% per year, meaning that within 20 years, 20% of that people will evolve into myeloma, but 80% might never go anywhere. That's why it's not cost effective doing tests for everyone at that age, because it's quite common, and it adds this stress and psychosocial issues. So that's something that we don't do for everyone, but someone that is already tested and we know what it is, we can actually define based on the markers whether the risk might be higher than that 20% or less than 20%, and whether by doing this test and having a research clinic in the setting, identify whether there might be more at risk of developing amyloid or having other symptoms that potentially could be related to this protein and that we can treat. So for every 7 patients that evolve into myeloma, there might be 1 evolving into amyloid. And we have an amyloid screening clinic. We do all these tests, and we actually do some assessments of the heart, assessments of the kidney, and we create this program that is called Amyloidosis Program of Calgary, where we got around 50 physicians and healthcare providers that help us diagnose people with amyloid, but also, and there are many different proteins that can actually make these deposits of amyloidosis, around 40. Light chain, which is associated to myeloma in small proportion, is the one that we see as hematologists, but we can actually get these people to help us diagnose even the other ones. So we have a group that is working on trying to get early diagnosis by using biomarkers and imaging studies that could potentially help us diagnose this. And we look at more than 240 patients, and we found 3 patients with amyloid just by doing this early test, and we found 1 patient that didn't have amyloid with a test that we did up front, but evolved into that. So by doing that in these clinics, we could potentially offer more sensitive tests. This is a cardiac MRI that we can look at the heart and see if these proteins are deposited or there are some changes. And we can actually look at other amyloid process and look at the cells from the bone marrow as well and see whether those cells might be looking more like amyloid producing cells. And for those people that we think might be at risk, we can even do tests when you inject tracers like the PET scan, but with a different tracer that could potentially bind not to the cancer cells. It could potentially bind into the proteins that these diseases actually get related to. And we did something that is quite unique here in Canada. It's the first clinic that we have in Canada that we created here in Calgary. And this is thanks to Dr. McCulloch, Sylvia McCulloch, which is another hematologist in the group, and Dr. Mackey, which is our pathologist, where patients actually get a screen for amyloid by doing a bone marrow and a fat pad if they have markers that may be suggestive for that. And this is quite unique. It's the first amyloid screening clinic that we have across Canada when we're trying to identify this, and there is a potential to do this research test added to some people that might be at high risk, with the hope to identify people with myeloma or amyloidosis sooner. So this is where we're moving in the future. Is we know the treatments are getting better, but we hope that perhaps by doing other tests that are more research-based that we hope to identify, we can actually define better what are the patients with these affected cells that can be at a higher risk to evolve into myeloma, and then identify those people and perhaps monitor them closely at the least, or actually do treatments even sooner to prevent them from getting the complications that people with myeloma can have. So this is just to give you an understanding of all the other problems that are related to monoclonal proteins that are not necessarily myeloma. And with that, I would like to thank you for the attention, and I hope that this is a more colorful picture of a better future for not only for you guys, but also for people that might not be yet myeloma patients that might be harvesting those cells that are at this point effective. And that's quite common. So you go to an audience that is more than 40 years, you might have three or four people out of 100 that might be actually having those proteins and they don't know. Perhaps digging a little bit more will help us in that sense. And with that, I thank you guys, and we'll take any questions that you have.
Hi there, thank you so much. I'm just wondering if people from Edmonton can get referred to the amyloidosis clinic of Calgary.
That's a good question. It is a little bit complex these days to see everyone in the clinic. So what we have offered, so we created this amyloid program, and what we have offered is amyloid rounds when we actually discuss people. We're trying to create an amyloid provincial group as well, including Edmonton folks as well, and we communicate with them. So it is, the answer is yes, we've seen some people that actually been referred to us, but the problem is like all the transplants that we do for Edmonton that are allogeneic transplant patients are really discouraged to come because they don't have the support in Calgary. They have to stay for longer. Patients with amyloid that might need to come to us might be a little bit sicker because of the heart damage or the kidney damage. So it is a little bit more complex in that sense because it is tough for patients to travel. We do have clinical trials that sometimes we share, but yes, with our group here in Calgary, we have a few different that Edmonton might not have, and that's just because this is a rare disease. So ideally, what we do is we set up these amyloid rounds at least every month within our group in Calgary, but we have also provincial amyloid rounds every couple months or every 3 months, where the people from Edmonton join us, cardiologists, neurologists, and hematologists, and they can actually discuss cases with us, not only with me, but also with the cardiologists, neurologists that we have in our group. So that is a way of trying to help them. Rather than getting patients necessarily to come, if they don't qualify for a trial, we can actually discuss some treatments or recommendations with the physicians down there. I know that Chris Benner was there and now is gone. So what we've been doing with Irwin and Michael is to discuss few cases, and sometimes we just give a recommendation that we put on the system on the note and discuss cases rather than getting patients to come. We got some people to come in, but my learning with that is that it's really tough for them to stay. Even if it is a couple days, it can be too much for them.
Perfect, thank you.
Yeah. I think she had a question.
Thank you. I just wanted to know, I have kappa-free light chain. I'm just curious about any tests that they have in the future. It seemed to be it's a lot of heavy chain-based research, in my opinion, and these the research that they're looking into and medications that are coming on the market, do they do any kind of testing with free light chain in mind, or does it make any difference? We are actually moving away from just looking at heavy chain versus light chain. We're actually trying to incorporate something that we call mass spectrometry that you might have heard of. Mass spectrometry is just a technique that actually is really sensitive at looking at proteins. You look at toxicology. The mass spectrometry is what we use in people that we want to find any drug in your system. Whether you take a baby aspirin and we want to see whether you're intoxicated with baby aspirin, what we do is We look at the blood, we look at the urine, and we see what are the proteins that you have in your blood and urine. And then we look at the mass of that protein. So like anything in physics, you have a protein, and the protein gives you what we call the mass. And there are proteins that are light because the mass is low. There are proteins that are heavy because the mass is high. That's why we separate the heavy chain versus the light chain. So this mass spectrometry can actually look at any single protein, whether it's a heavy chain protein or light chain protein, because it looks at the mass, and it tells you this is a mass that we see of this protein at these kilodaltons. So with that said, that means that if you have 20 IgG kappas, because that's a very common protein. IgG kappa is type of protein that we use to make all the antibodies in like daratumumab, elotuzumab, all the antibodies that we use, monoclonal antibodies that we use to treat myeloma are IgG kappa based. So if you run a test, a monoclonal protein test, which is the SPEP, you're going to find these proteins and you wouldn't know whether that is an IgG kappa because of the antibody versus an IgG kappa because of the myeloma, which is around 60%. So by doing the mass spec, you can actually determine whether it's the antibody versus your myeloma, because it looks at the exact mass of that protein and it tells you the differences. So more than trying to identify the heavy versus the light chain, the future might be the mass spectrometry. And the Mayo Clinic is actually using what they call mass fix that actually replaces now the immunofixation. So they're not doing immunofixation anymore. They are doing this test. And there were a couple of groups that actually look at mass spectrometry even for MGAS. But the problem is that by doing more sensitive tests, you actually identified a lot of people with more proteins that may actually not have any clinical significance. So that's the problem for the future, is that these tests are so sensitive that are likely gonna overdiagnose a lot of people that shouldn't necessarily be worried about it. So more than doing the heavy versus the light chain test, this mass spectrometry will help us better monitor people with myeloma, regardless of what type of protein they have, because it can look at anything, whether it's a heavy chain or light chain, whether it's the same heavy chain but with different treatments, because those treatments are coming, like all the monoclonal antibodies, so we have to use those tests. So mass spectrometry is what is coming in the future. And that is a hope that actually can be even partnered with a bone marrow and a blood test to actually help us define better what we call minimal residual disease, meaning that they're looking at the bone marrow and the blood to see whether we can do this test, this mass spectrometry, this very sensitive test just in the blood to avoid people from getting the bone marrows. And so far the sensitivity is not the same as getting the bone marrow, but as the technology is improving, the hope is that perhaps in a few years we might be able to just do a test in the blood and see if these proteins are present there, and there are no proteins, we might assume that there is no myeloma cells growing. Any other questions?
Yeah, my name is Milton Brown. I was diagnosed 1995, the 28th of July. I was 41 at the time, and they told me that myeloma was for people in the 50s and 60s. And they was checking about why, because it was 3 of us at the time, Baker, that at my age, that with myeloma. Mm-hmm. But I didn't hear, they found out why I was diagnosed with myeloma. So it's been almost 28 years now since myeloma, right? Mm-hmm. But I'm doing okay. But my problem is I was doing treatment a couple months, 4 years now, with this new drug called synthetic treatment. I don't know if you know of it. I was doing it at the Tom Baker. Mm-hmm. And unfortunately for me, my doctor didn't tell me certain things about some of the medication that I'm taking, right? Now, I have high blood pressure, high sugar, diabetes, which none of my family have these things, and it's hard for me, right? I was doing okay, up to 2017 until I fall and break my wrist, right shoulder, right leg. And my doctor said, is the myeloma come back? So I'm doing all right now because I just went for my 6-week checkup. The myeloma is stable, but my blood sugar is going up, and it's crazy. So I always want to know what, I think for me that our doctor should tell us certain things with certain medication, right? As a myeloma patient, because you don't want to take care of something and then something happen. I don't know if you understand what I'm saying.
Yeah.
But I appreciate the treatment that I'm getting. I don't know, but because for me, I know if I was in Jamaica, I wouldn't get this type of treatment, right? I know for sure because I went to Jamaica and my doctor told me that. So I'm blessed to be in a country like this with this sort of treatment that I'm getting, So that's what I have to say. Thanks.
No, thank you for coming. And you're right. In the past, we used to, like many of us, we deal with cancer, and we'll sometimes, and that's also important for you guys to know, we sometimes concentrate on more treating the cancer, and we forget about the other things that have to do with that. These days, an unmet need with the new treatments that we have is to make those treatments not only effective, but make those treatments tolerable and to give you a good quality of life. So in the past, when we didn't have a lot of treatments available, more of the idea was let's give something that can keep you alive and hope that will keep you alive for the longest, and then at some point something will be better. And then we moved from using the steroids, like the ones that can induce diabetes, doing dexamethasone 4 days on, 4 days off, that we used to do not long ago, like 10 to 15 years. And we do sometimes for some people that we want to recover the kidney function when they are diagnosed earlier, that we try to treat a tumor that is growing really fast. But now we're actually moving to the point that we have new drugs that actually can compensate for that. The steroids are not chemo, but they make all the chemo work better. Some people call it is the bacon of the breakfast. It goes well with everything. It goes well with the eggs. It goes well with the fruit, whatever you put on it. But it comes with other side effects that have nothing to do with myeloma, but can trigger the blood pressure, can trigger the sugar, can make your mood change. So there are a lot of things that now that we have new drugs, we actually can drop a little bit doses because we have treatments that can help us compensate what we might lose by dropping that dose. Is we get a treatment that works better. We use the treatment with the steroid a little bit more at the beginning, and then when things are stable, maybe we can drop it down. So that part is important, and we're a part of you, but also you guys are getting older. So as we get older, that's what we want. We want you to get older. We want you to enjoy things in life. But as we get older, we also get things that comes with age. Blood pressure, hypertension, kidney problems. So all these cells get older. Not only myeloma is necessarily the cause of everything. So that's why we need the help of other doctors. That's why we need you guys to do screenings for other cancers. So there are many things that you guys have to consider, and also important, and that's just to close. I know the next speaker is coming. The psychosocial part is really important. We sometimes forget about those things, and people sometimes don't talk to the family because they don't want to pass the worries that they have to the family, and they just keep it for themselves. I always tell my patients that that's an open invitation for any psychosocial support, that this is not only a physical journey, it's a mental one and a spiritual one. And sometimes people concentrate more in trying to make the treatment work and kill the myeloma, and we forget about the other parts. The other parts are also important, and we're here to help you with that as well. So that's just to say that this is a whole journey, and we'll pass to the last question, I guess. That's my pager, but sorry for that.
So, all right. So we're just going to go with a last question online. So we have Sharon asking, I missed the name of the disease Dr. Zepeda mentioned that had some of the symptoms of MM, but wasn't MM. So was it POM or anything else?
Yeah, there are different conditions that can have some symptoms that are not necessarily related to myeloma, but sometimes can mimic the same in terms of having a monoclonal protein or having neuropathy that sometimes we can see in people with non-myeloma but amyloid, or people that can have pains in the bones, but not because there are holes in the bone. There's something that we call a sclerotic disease, where they have a lot of inflammation in the bones and it gets like a chronic scar that gets on the bones and gives some pain. That is a disease called POEMS syndrome, POEMS, and that stands for polyneuropathy organ enlargement, particularly liver, spleen. They have a monoclonal protein, that's the protein that we see in MGUS, also myeloma and other problems. They have skin changes and endocrine changes, hypothyroidism, diabetes, other problems that are related to that. So by having these clinics, we could potentially look at things more from the research perspective at this point and try to find biomarkers that will help us find the right people that might need to be followed up closely or that we might have to treat even sooner, or even identify other medical problems that we can actually offer treatments to help with the symptoms that are no myeloma, lymphoma, and amyloid, and those are what we call monoclonal gammopathies of clinical significance. That can affect the kidneys, that can affect the nerves, the eyes, different organs. So we have, we're thankful to have a very comprehensive group here in Calgary that actually looks not only at the myeloma part or the amyloid part, we also look at the benign form, and we have this MGUS or MGCS clinic, and hopefully with the amyloid screening clinic, we can actually diagnose hopefully amyloid earlier. So there is a lot of work to do, but we're here for you guys and for the next guys to come. We're trying to also learn more and try to identify people hopefully earlier and continue advancing on treatment. So Dr. Bailey is going to talk about all these new research treatments that are really exciting, just to give you an idea where we are, but things in the future look really promising. Things at the present look really exciting and promising as well. So we can keep the myeloma well controlled for a few more years. Who knows, we will be in a few years. So the hope is that in a few years, we might be way better than we are now, and hopefully in a few years, we might be talking about a real cure for you guys. And that's the hope. So thank you for the invite. Thank you for being here. And I'll see some of you in the Cancer Center. But it's been a pleasure like everyone.